everybody. Today this is about bacterial keratitis for the general ophthalmologist. We welcome you all to this session. We shall start with the first thing we will be dealing with will be the diagnostics. So we'll be starting with that. I'm Dr. Geeta from GP123 and we'll be starting. Thank you. I would like to introduce the other participants, other speakers of this session. Dr.
I'm Dr. Hemlata Gudiseva. I'm from Andhra Pradesh, Eluru. I'm Director Corneal and Refractive Services. So I will be speaking on spectrum of viral keratitis and its management.
Good afternoon, everyone. I'm Dr. Jeenu Priya. I'm Director of
The mic is mic. Yeah. Please introduce yourself.
Good afternoon, everyone. I'm Dr. Jeenu Priya. I am working as Director at Cataract and Cornea Refractive Surgery at Lokpriya Eye Center, Meerut.
Thank you. Right. Okay. So just to recap very briefly, in the clinical diagnosis, it is very important to look at the risk factor assessment as well. So one has to look at ocular cues. For example, in the lids, if there's any abnormalities, for example, exposure keratitis, any history of trauma or insect or chemical injury, contact lens usage, which is one of the most common causes of keratitis, particularly in the West, but in our country, trauma dominates. When there is a history of contact lens use, you would like to ask about the frequency of use, overnight wear, solution use, whether tap water was used for cleaning it, type of the contact lens, whether the person took a bath in the swimming pool with the contact lens on, or the use of cosmetic colored contact lenses in which the diagnosis may be delayed or patient may not have realized at all. Other ocular diseases which also predispose to corneal ulcers are viral and previous similar episodes, medications like steroids, medication allergies, ocular surgery, and dry eyes. Systemically, one must look for immunosuppression as well, malnutrition, vitamin A deficiency, HIV, or immunocompromised states. So the presentation is fairly straightforward. I'm sure most of you are familiar with it. Pain, redness, watering, mucopurulent discharge, photophobia, defective vision, foreign body sensation. Usually bacterial keratitis, the history would be for 2-3 days, not more than that. And along with that, there will be other signs like circumcorneal congestion, epithelial erosions, stromal edema, Descemet's folds, endothelial plaque, hyperpion, and anterior uveitis. So what are the special features related to certain organisms? The most common organisms identified in corneal ulcers are the strep and the staph species. So strep species can cause something called as ulcus serpens, in which there is a progressively infiltrating ulcer from the periphery to the center. Staph aureus usually is oval, yellowish white, opaque, deep with a stromal abscess. Staph epidermidis, again stromal abscess, but it's slightly less severity as Staph aureus. Sometimes it's just a superinfection over an erosion. Moraxella may be seen as a paracentral oval stromal ulceration with undermined necrotic edge and corneal perforation. Bacillus cereus, you will see stromal ring infiltrates. Nocardia again has a very atypical presentation, a wreath-like or necklace configuration with a brush fire border and pinhead lesions. Pseudomonas, one of the most dreaded organisms. It has a ground glass appearance, marked stromal melting and ring infiltrates. Klebsiella, when we grayish white pleomorphic separation with diffuse stromal pallescence. And then you have the non-tuberculous mycobacteria, which typically are described as a cracked windshield appearance seen post-LASIK cases, but that is not always the case. That said, it is near impossible to clinically distinguish between organisms based only on appearance, and it is not recommended to treat based solely on the clinical appearance. So one has to do the needful. But before you do that, you look for other things. The sclera should be examined very carefully for inflammation, for ulceration, thinning nodules, basically scleral involvement. cornea, one must look for desmetocele or perforation. Any inflammatory glaucoma, and that will also retard healing. Complicated cataract. And on B-scan, it is very, very important to rule out endophthalmitis in every case of a large ulcer. So what do you do? So when do you do a corneal scraping? Ideally, all ulcers should undergo a scraping. But particularly, suppose you have a very small peripheral ulcer, you might decide to go empirically with monotherapy. But cases where you must do a scraping are the large central corneal ulcers, chronic and unresponsive to broad spectrum antibiotics, previous history of corneal surgery, patient is on steroids for a long time, and any atypical clinical features. The reason being that you may not be, your empirical therapy may not work in atypical ulcers, and you really need to identify the organism fast. So you must go ahead with the scraping. So how do you do it? So the very basic requirement for the scraping is for these two things. There is a Sabros dextrose agar plate and the blood agar and slides and the needles. One can also use 15 or 10 knives, and or blunt instruments. So use Paracaine to anesthetize the eye, give it a minute, and then you can scrape. You can either use a blunt instrument initially, and if you think the yield is not so good, you can go in with a 15 or 10 blade, 11 blade, but please be very careful when using the blades because you should not end up perforating. If the patient is not comfortable sitting, you can even make the patient lie down and then take the scraping from the base and the edges. So what you do is first you put it on the slides for staining, and when you do that, you must always mark the area where you have spread it out so that the microbiologist knows that is the area to be examined, and also put a small mark there and label it for a gram staining or for a KOH. Now, you must take the scraping once more using another sterile instrument before putting it on the culture plates. This has to be done twice. You should not use the same thing that you have used on your slides. So you've got to take new instruments, scrape again, and then put it in C shapes. Because if you see something growing along the C shape, that is the organism. Anything that doesn't grow along, they may be contaminants. So that is why it is important to put it in a pattern, right? So what is typically done? This is the very, very basic evaluation. So you routinely do a grams and a KOH. So the grams is a very good stain which identifies a host of bacteria. A good microbiologist may even be able to see fungal hyphae and acanthombastis. It can be picked up, but though it is not the investigation of choice. The KOH will pick up any fungal hyphae or any acanthombastis. Blood agar and SDA agar are the standard culture media which is done always. Additionally, one may use non-nutrient agar for acanthamoeba, or one may use special culture media depending upon the suspected organism. That usually this is done in conjunction with the microbiologist. So you may, if recommended, they may culture it further on chocolate agar for so many other organisms, or for particularly Neisseria, and for anaerobic organisms, cooked meat broth is used. Nocardia again requires specific media, but Nocardia grows well even on blood agar. It is seen as chalky white colonies, but special media are very useful. So these are the various media: chocolate agar, blood agar, everything I spoke about. Lowenstein-Jensen media is used for mycobacteria, but as of now, there are still better methods for mycobacteria, like your MG tubes or Gene Expert, but Gene Expert is not available for the atypical mycobacteria. So only scraping. So what else can be done? Suppose the scraping is negative and there is a progression of ulcer despite best antibacterial therapy. What can you do? You can take a conjunctival swab. Simple calcium arginate swabs sometimes are very useful. They might grow some atypical organisms. There might be some confusion, but some information is better than no information. Contact lens cultures are very, very important for contact lens users. The lens, the solution and cases, everything should be cultured. Anti-rich hemoparacentesis can be done for very thick exudates. We have done and identified nocardia through anti-rich hemoparacentesis culture. Corneal biopsy can be done in very extreme cases if nothing is growing, particularly deep fungal abscesses. Corneal biopsy is used. Usually a 6 or 8 sil suture is passed from the normal to abnormal area, and that is sent for culture. So what are the newer diagnostic modalities? Now these are, you have other things like immunohistochemistry, enzyme immunoassays, you have PCR and radio immunoassay, but these are of limited role in bacterial keratitis. PCR is very often used in advanced centers for fungal keratitis and atypical organisms. But you have something called a MALDI-TOF. This is a new technology which is used in major centers. This allows for very rapid identification and speciation of bacteria. It is very fast and accurate. And though there's a high initial cost of equipment, once there, the speciation it comes right down to the speciation. You do not require that extra 24 to 72 hours, 24 to 48 hours for speciation and sensitivity testing. The Vitek 2 complements the MALDI-TOF system. It can identify microbes and perform susceptibility testing in 5 to 8 hours. So many advanced centers, many advanced institutes now rely on MALDI-TOF and Vitek 2 for bacterial cultures and sensitivity testing. Management, again, it's very straightforward. We are looking only at medical management first. So topical, you give antibiotics, anti-glaucoma medications, cycloplegics, and lubricating drops. Systemically, you may give antibiotics and anti-inflammatory drugs. But look at general measures are dark goggles, avoid direct exposure to sunlight, excessive eye rubbing, applying soap or direct water splash into the eyes, rest, good and timely diet, and hot fermentation. Now coming to the topical antibiotics. Peripheral ulcers not involving the visual axis, monotherapy with third generation fluoroquinolones like 0.5% moxifloxacin, 0.3 or 0.5% catafloxacin work very well. These have to be given on a 1 hourly basis, round the clock, very strictly, 24 hours, 24 times, has to be told very strictly to the patient. Patients who comply recover very fast. Larger and deep stromal ulcers, better to start with 2 antibacterials, fortified cefazolin 5% to cover the gram-positive, fortified topical tobramycin 1.3% or gentamicin 1.3 or amikacin 1. Depending upon this setup, community setup, hospital setup. This has to be again put 24 hourly, round the clock, once every hour. Patient has to be told 24 times, 24 hours. So no rest for at least 48 to 72 hours for 3 days. Once it starts getting better, you reduce it to 2 hourly. Targeted antibacterial therapy, culture and sensitivity report comes in after 48 to 72 hours, and we then change the treatment as per the therapy. Other topical medications I just told you as per requirement, and if there's a good response to treatment, you will see a reduction in the pain. Patient will report reduction in the pain, reduction in ulcer size, blunting of ulcer margins, and there will be healing of the epithelial defect, hyperpyon will resolve, visual acuity will improve, and there will be some vascularization. Poor response, worsening of symptoms, increase in the size of ulcer, more feathery margins, stromal thinning, increase in the exudates, hyperpyon, perforation, all those things will happen. Scleral involvement can also happen. Systemic antibiotics are usually indicated in scleritis, endophthalmitis, and non-resolving and progressive ulcers. Fluoroquinolones are preferred because they have a much better penetration in the eye as compared to the other antibiotics. And other antibiotics are aminoglycosides or cephalosporin. Surgical, if there's an impending perforation, patient has to be told to avoid excessive coughing and straining, start AGMs. Small perforation can be dealt with glue BCL, but a word of caution. If you put in a small BCL, you may not know, you may not be able to assess the progression underneath the BCL. It might work counter to what you have been trying. Therapeutic keratoplasty is absolutely required in large perforations. Non-healing corneal ulcers for 2 weeks or larger perforations, you need to eliminate the focus, and it's essential for restoring the anatomic integrity. Surgical pearls, ERR, trephination of the host cornea, 0.5 mm margin clearance is required. Graft is kept 0.5 mm larger. Graft is sutured to the host with 16 interrupted, always interrupted, so that we can remove any infiltrates or any vascularized areas. Removing exudates from the anterior chamber and angle. Release of pus, peripheral iridectomy. Lens is removed if needed, but kept most of the time to prevent a progression to endophthalmitis. If PC is breached, then thorough antirectectomy with antibiotics posteriorly. Thank you.
So good morning everyone. So I'll be speaking on spectrum of viral keratitis and its management. So we know viral keratitis is basically divided into 2 types, that is herpetic and non-herpetic eye disease. The herpetic eye disease is again subdivided into herpes simplex and zoster, whereas non-herpetic is mainly adenoviral. So the main feature that differentiates a viral keratitis from bacterial, fungal and other types of is its recurrence. So which is mainly stromal and endothelial, which leads to scarring and neovascularization, and it is a cause of the major morbidity even when the disease is inactive. So based on the type of response, it is divided into infectious, immune and neurotrophic, where based on anatomic location, it can be epithelial, stromal or endothelial. So based on these two types of response, it is broadly classified into 4 types, so which I'll be discussing in my next slides. So the infectious epithelial keratitis is mainly can occur as corneal vesicles or dendritic ulcer or geographical ulcer. So the corneal vesicles usually appear as small raised vesicles which are analogous to the vesicles on the skin surface. So these patients usually present with pain, photophobia, watering and defective vision, and these patients are mainly treated with topical antivirals which should be started at least 5 times per day until the vesicles disappear, and then should be tapered 3 times a day for another 1 week. So at this stage, topical steroids are contraindicated and lubricants can be given at this stage to relieve the symptoms. So this stage should not be confused with the microsporidial keratitis, which have small creamy lesions in the epithelial surface which have stuck on appearance. So these patients usually give the history of fall of rainwater or dirty water in the eye, and these patients are usually treated with lubricants with or without epithelial debridement and which are confined to the epithelium. So next comes when this corneal vesicular stage, when we treat the patient with topical steroids or if the patient is immune suppressed. So these patients can develop a linear branching pattern like this, and which have large terminal bulbs with an inflammatory epithelial border which has active viral replication. So these patients are again treated with topical antivirals 5 times per day until the ulcer heals, and then should be tapered to 3 times after another 1 week. So next, when the dendritic ulcer is again treated with topical steroids, or if the patient has immune suppression, he can go into develop geographical ulcer which has this geographic pattern, and these patients have a scalloped edge, and they also have the inflammatory border with active viral replication. So these patients are again treated with topical antivirals 5 times per day until the ulcer heals, and at this stage the head study they have done, and they have seen that there is no benefit of adding oral SCV to the standard topical treatment to prevent future development of stromal keratitis. So again, a history of HSV epithelial keratitis is not a risk factor for recurrent epithelial keratitis. So the next stage is the stromal keratitis. So here we have 2 types. One is immune stromal keratitis and necrotizing stromal keratitis. The immune stromal keratitis can be disciform or interstitial keratitis. So mainly the stromal keratitis is due to immune response to the viral replication in the stromal keratocytes. So we'll see this immune stromal keratitis or disciform keratitis has central corneal edema which is surrounded by clear stroma. So these patients should be started with prednisolone phosphate at least 8 times per day and should be tapered for 10 weeks, and these patients can be added topical antivirals or oral SCV. And we have to remember that according to head study, the addition of topical steroids showed faster resolution and less treatment failure compared to patients who are on placebo treatment. And they also shown that there is no benefit of adding both oral and topical antivirals at the same time. Just give one, either topical or oral antivirals. So the next is a necrotizing stromal keratitis. Usually these patients have yellow to white stromal ulceration surrounded by dense infiltration and with a clear stroma around. So these patients usually this dense stromal infiltration is due to hyperimmune response to the viral replication in the stromal keratocytes. So these patients again should be treated with topical antivirals until the epithelial defect heals, and once the epithelial defect heals, you can give topical steroids and oral or topical antivirals like how you have treated an immune stromal keratitis. So according to head study, again here there is no benefit of giving both oral and topical antivirals to prevent future development of stromal or keratitis or iridocyclitis. So this is a case of recurrent stromal keratitis. So here this patient is almost coming to me the third time. So even though I keep him on prophylactic antivirals, once I stop the prophylactic antivirals, again he comes back with recurrence. So according to head study, the prophylactic antivirals 400 mg twice daily at least reduce the rate of recurrence by 41%. And they also shown that as recurrence is associated with scarring and vascularization, at least a low dose prophylaxis is recommended at least for 1 year or longer in patients with recurrence. So this is again a recurrent HSV keratitis. You can see dense scarring, new vascularization and edema. And these patients, so according to head study again, the epithelial keratitis is not a risk factor but epithelial keratitis, but we have to remember that recurrent stromal keratitis is definitely a risk factor for stromal keratitis by 10 times, and they have seen that stress, UV exposure, contact lens wear and systemic infections are not associated with recurrence of ocular HSV. So coming to endotheliitis, this is also an immune response to the endothelial cells which lead to corneal decompensation with stromal edema and epithelial edema. So these can present as either disciform keratitis which have clear disc edema with keratic precipitates only confined to the disc shaped edema. Again we have the linear endotheliitis where the keratic precipitates are confined to a linear pattern and with the trailing corneal edema. And in diffuse endotheliitis, we have diffuse corneal edema with the dispersed keratic precipitates and corneal edema from limbus to limbus. So this is a disciform endotheliitis. We have keratic precipitates and edema confined to a disc-shaped form. In these conditions, patients should be treated prednisolone phosphate 8 times per day and should be tapered for 10 weeks. And here definitely there is a role of oral acyclovir which should be given at least 5 times per day for 10 weeks, which helps in better resolution of iritis. So neurotrophic keratopathy, usually these patients, they first initially present with punctate epithelial erosions which then progress to persistent epithelial defect, and these patients usually have an oval shaped ulcer either centrally or paracentral inferior part of the cornea, and these patients should be treated with topical lubrication, preservative free artificial tears, gels and ointments, and punctal occlusion helps in better resolution. Adding of oral tetracycline or doxycycline helps to reduce the mucus produced and helps in healing. And these patients can also be given 20% autologous serum which is effective in stages 1 and 2. But if the patient doesn't heal with this above treatment, then we have to go for surgical treatment like tarsorrhaphy or palpebral sling or botulinum A toxin in the levator muscle. Conjunctival flap can also be considered, but poor cosmesis usually we do not prefer, and amniotic membrane transplantation is definitely another good alternative if you go for surgical procedures. So the next comes is the herpes zoster ophthalmicus. This is due to viral reactivation along the trigeminal nerve, and 50% and we have to remember 50% of untreated patients will go to develop ocular complications, and these are the most common types of presentations like conjunctivitis, uveitis, keratitis, episcleritis and chemosis. So when we see a patient within 72 hours, always start with 800 mg SEV tablet 5 times for 7 days, and other alternatives are valcyclovir and famlocyclovir, and this at any ocular presentation, this treatment should be started, and patients, it reduces the risk of ocular complications by at least 20 to 30%. And patients, if it does not prevent post-herpetic neuralgia, but reduces the duration of pain by at least 50%. So finally, the points to remember: in patients with epithelial keratitis, there is no benefit of adding oral acyclovir to prevent future development of stromal keratitis. And in patients with HSV stromal keratitis, always start topical steroids which have faster resolution. So in patients, again with stromal keratitis, there is no benefit of adding both topical and oral antivirals. And with patients with iridocyclitis, always give oral acyclovir 5 times for 10 weeks, and topical steroids help in better resolution. And in patients with recurrent stromal keratitis, always give prophylactic oral acivir for at least 1 year. And remember that stress, UV exposure, contact lens, all these are not associated with recurrence of ocular HSV. And I would like to thank the scientific committee for giving me this opportunity. I would like to invite Dr. Jeenu Priya for our next presentation. Thank you very much.
नहीं आ रहा है वहाँ पे. हाँ, स्लाइड शो की नहीं. A very good afternoon to all of you. At the outset, I would like to thank AIOS for giving me this opportunity to present my views on this topic before you. So I would like to ask how many of you who are doing the treatment of microbial keratitis are routinely performing the microbiological culture or smear testing. So ideally, what the approach is recommended is, after your clinical diagnosis, it should be confirmed with direct smear and microbiological culture and sensitivity, and then specific antibiotics should be started. But practically, that is when solo practitioners are concerned, that is never the case. This is a study done by LVPI in which even more than 90% of solo practitioners were giving empiric treatment only, and they were giving even corticosteroids without doing microbiology. So what is the reason of this behavior? When all the guidelines suggest us that we should do microbiology before starting the treatment in case of a corneal ulcer, why ophthalmologists are not doing? Because of the microbiological workup needs a well-equipped laboratory and microbiologist capable of dealing with small ocular samples. Then we need a trained staff, and it increases the cost and logistics, and this is difficult both for the ophthalmologist and the patient. And sometimes the microbiology may be repeatedly negative, whatever you do. And the culture reports take time. So until then, we have to prescribe an empirical treatment. So early and appropriate treatment reduces the morbidity in corneal ulcer, and sometimes the reports are unreliable. In that case, our clinical judgment is better than the lab reports. So to solve this dilemma, WHO conducted a workshop in 2005, and they gave us some guidelines. In those, if it is a significant number of corneal ulcers are bacterial, and most of the antibacterial agents are bactericidal, and their effect can be demonstrable within days. So it is advisable that if it is a mild corneal ulcer, less than 2 mn, then you can start the antimicrobial treatment without doing any microbiology. But if you suspect fungus, then it is necessary to do a 10% QH test. You are not recommended to start an antifungal treatment without looking for the hyphae in the 10% QH test, which is a pretty simple test to do. But in large and serious ulcers, they should be referred for microbiology, because the case may deteriorate and it may not be amenable to treatment after that. But the teaching institutions were advised to do microbiology in each and every case, so the epidemiology of the area is known. So if you want to target your target without seeing the target, you want to hit the bullseye, you need more knowledge actually. You need to know thoroughly about the history of the patient, the predisposing and risk factors of the patient, and in what geographic area you are practicing, whether you are practicing in rural area, urban area. It is well known that in North and West India, aspergillus is more common in fungus, and in South and East India, fusarium is more common. So you should know about the various clinical presentations about the bacterial, fungal, viral, protozoal, and non-infectious corneal ulcer manifestations. And the sensitivity patterns of the organisms should also be known. So you should form a clinical judgment. We should clearly differentiate between bacterial and fungal. So this is a study done by Schroff Eye Center in which more than 96% of the cases comprise of bacteria and fungi combined together. So if you are able to diagnose or differentiate between bacteria and fungal corneal ulcer, then half of your job is done. There were 2 studies in which clinical corneal specialists diagnosed corneal ulcer on basis of slit lamp examination only, and 3/4 of them were correct in their diagnosis. So how should we go about the empirical treatment? First, we should take the history about the duration, because there are certain organisms which rapidly progress and certain which are slow growing. Then trauma or any sac disease, conjunctiva, ocular surface disorder, any history of contact lens use, recurrence of disease, whether the patient has taken any past treatment and its response. And systemic factors like diabetes, immunocompromised status, etc. should be known. So certain risk factors, which are local risk factors, should also be taken into account, like entropion, ectropion, seventh nerve palsy, or dry eye, or any ocular surface disorder like vernal catarrh, neurotrophic, or bullous keratopathy. And then occupational risk factors should also be taken into account, like if the patient is farmer, animal handler, or gardener. So after that comes the evaluation part. So in evaluation, you should first look at the patient in general. What is the skin condition? What is if there is any leg ophthalmos, any eyelid abnormality, and check for the corneal sensations, visual acuity, and intraocular pressure. Then we should go in for the slit lamp examination. First, you will examine the eyelids. If there are any eyelid disorder, any MGD or any NLDO or any punctal abnormalities, or tear film disorder like dry eye. And then you should look for conjunctiva, whether there is discharge, erythema, follicle, etc. And then you should look for sclera for inflammation, ulcer, and nodules. And then you should go in for anterior chamber examination, in which if you find this fixed hypopion with convex margins, then it is most likely to be fungal with fungal hyphae in it. And if you are able to see this mobile hypopion which moves when the patient moves their head, then this is mostly due to bacterial corneal ulcer. Then you should also document your findings, because then only you will be able to see whether the patient is improving or not. You should document the visual acuity, size and depth of the ulceration, stromal edema, infiltrate, and then the hypopion AC reaction, intraocular pressure, and also B scan to rule out any endophthalmitis, especially in severe cases. So usually there are defense mechanism in eye which prevent corneal ulcer from developing, and most important from that are tear film, which has IgA complement, lactoferrin, our blinking mechanism which reduces the temperature of the eye, and then anatomical like intact corneal epithelium, eyelids, and bony orbit. So once the organism surpasses these protective mechanisms, the patient develops a corneal ulcer. So first of all, the patient will adhere to the corneal epithelium, and then infiltration will start. This is the stage of progressive infiltration. Then there will be active ulceration, where the size of the infiltrate increase and there is active necrosis. Then the body defenses and the antibiotics start working, and there is stage of regression. And finally, the inflammatory tissue is replaced by the fibrous tissue. And there is stage of cicatrization or scar formation, which we all want. So we should grade the corneal ulcer so that we can manage it properly. So mild corneal ulcer, less than 2 mm, something like this, less than 20% depth, superficial, and moderate corneal ulcer, 2 to 5 mm, 20 to 50% depth, and infiltrates reach up to mid-stroma. And severe corneal ulcer, more than 5 mm, more than 50% of the depth is involved, and they reach, infiltrates reach deeper than mid-stroma. So then we should note about clinical features. We all know about them. A patient will complain of redness, photophobia, defective vision, pain, discharge, and there will be signs like emesis, eyelid swelling, conjunctival injection, epithelial defect, and DM folds, and sometimes desmetocele or corneal perforation, and hypopion. So once you have analyzed your patient and you have a patient sitting before you who, where corneal ulcer looks like this, which is a mild corneal ulcer, less than 2 mm, 2 mm away from the visual axis, less than 2 plus AC reaction, it's not having any feature of fungal or parasitic ulcer, and not having feature of rapidly progressive ulcer, then you can go about treating that ulcer with monotherapy with fluoroquinolones. This has been proven in bacterial keratitis study that monotherapy with fluoroquinolones is as effective as fortified eye drops. So you can take any fluoroquinolone, but 4th generation gatifloxacin and moxifloxacin are preferred, and even the new levofloxacin concentrated 1.5% is also a good option. So you should start with a loading dose, which can be given in clinic itself every 5 to 15 minutes in the first hour. After that hour, it should be given hourly till 48 hours. And after 48 hours, you should examine the patient. And if you are seeing adequate response after 48 hours, then you should reduce it to 2 hourly. And then you should continue the treatment till reepithelialization occurs. And after that, you should continue 2 weeks after the healing. So to summarize, less than 2 mm ulcer, monotherapy with fluoroquinolone is sufficient. More than 2 mm ulcer, fortified cefazolin 5% or vancomycin or combined with ciprofloxacin and like tobramycin 1.3% should be given. And there should be no steroids to be given in empirical therapy. Steroids can only be given if you have culture report with you. So after that, you should be able to see if the patient is healing or not. The patient will be more comfortable. The patient before he was not able to open their eyes, they will start opening their eye. There will be decrease in all the signs and symptoms of pain, lid edema, redness, discharge, infiltrate area, size, density, margins, and hypopyon. So if after 48 hours the case is worsening or it is not responding on empirical therapy and you have not access to microbiological workup, then you should better refer the patient. And also if the patient is one-eyed, severe central perforated corneal ulcer or pediatric or post-LASIK or post-cataract surgery, contact lens induced, then hospital acquired also, you should refer the patient. Then these are well-rounded, well-circumscribed corneal ulcers with relatively clear cornea which belong to gram-positive staph aureus, and these are due to pneumococcus, which are rapidly progressive serpiginous ulcers with one active leading edge. These are gram-negative bacteria, ground glass appearance, greenish yellow discharge, and rapidly fulminant, perforates in 1 to 2 days also. And if the patient gives you history of farming background, then diabetes or any corneal epithelial disorder or history of trauma by vegetative material, then you should suspect fungal ulcer. There will be dry, thick hypopyon with feathery margins, with satellite lesions, with endothelial plaques. This is dematicious fungi with abscess and this fixed hypopyon. So you should start treatment. Then you should do 10% KOH staining, and if you are able to see fungal hyphae on that, you should start with 5% netamycin. 1 hourly in daytime and 2 hourly in nighttime, and then taper after 7 days. If the patient is responding, continue the therapy for 4 to 6 weeks and 2 weeks after healing. And after healing, after 2 weeks, you have to again call the patient. Then if the patient is worsening, you should add amphotericin B or voriconazole and refer the patient. So this is a TST protocol, which is very good. But if you are suspecting corneal fungal ulcer on clinical basis and no fungal hyphae is seen, then you have to refer the patient. So no role of steroids in empirical therapy. It is proved by SCUT, and adjuvant treatment like cycloplegic pain management, anti-glaucoma, and lubricants can be given. So these are differential diagnosis: wreath-shaped ulcer of nocardia, ring-shaped and ulcers, and this radial keratinitis of acanthamoeba, and these are microsporidial keratitis with coarse SPKs and stuck-on appearance, and all the rest of the cornea is clear. And this is the stromal microsporidial keratitis, which you should better refer. This is moraxella, which occurs in chronic alcoholics or diabetics and malnourished. This is a classic windshield appearance of atypical mycobacteria, and this is pythium keratitis, which looks like fungal, but it is very devastating. Even if you give all the correct medical therapy, usually patient lands up in surgical, and you may even lose the eye. And these are non-infectious keratitis like foreign body granuloma, bee sting, drug toxicity, or VKC shield ulcer. So in summary, after you examine the patient in detail about history, predisposing factor, past treatment and response, systemic conditions and clinical feature, you should be able to make a clinical judgment about whether the person or patient is having a bacterial, fungal, viral, parasitic or non-infectious ulcer. And then you should start the empirical treatment. If the ulcer is mild, then start with monotherapy with fluoroquinolone. Observe and see the patient after 48 to 72 hours. If the patient is improving, well and good, continue. If the patient is not improving, then you have to refer the patient to some place where smear and culture sensitivity is done. And take-home message is that in empirical therapy, bacterial corneal ulcer with mild less than 2 mm can be treated with monotherapy, and severe microbiology should be done. And in fungal, you should do 10% QH. If you see fungal hyphae, then 5% netamycin should be started. So to conclude, in this slide, I just want to show that when the patient goes to tertiary center, it is already, the clinical picture has already distorted. So when the solo practitioner sees the initial nascent picture of the patient, in which you can make out the textbook diagnosis by seeing the slit lamp also. So you are in good position to start an empirical treatment, but you should be having a good judgment when to refer the patient. Thank you for your patient listening.
Any questions from the audience regarding empirical treatment or viral keratitis? And we have one more presentation. Actually, it has to be presented by Dr. Anu Malik, and Dr. Jinu Priya is going to present on behalf of her.
I have a question regarding the side effects of oral acyclovir. When it can be given up to a year, should we have concern about the side effect of oral acyclovir? Anything like that?
You have to do renal profile before. So every 3 months, it's better to repeat.
So
like
only renal toxicity we have to monitor.
yes, renal and liver also you have to do.
Okay. Thank you.
I have one question. I have patients of acyclovir using patients. So whenever I stop acyclovir, I am giving you only 400 milligram twice daily, and whenever I stop acyclovir, it recurs.
Yeah,
How long can I continue?
it is recommended to continue 1 year, but even after 1 year also you can, because once you stop the acyclovir, its protective effect is going to wane off immediately. So it has been proven that there is no acyclovir effect once we stop it. Okay, if patient has recurrent keratitis, you can continue like even after 1 year.
So good afternoon, everyone. I am presenting again. This was originally to be presented by Dr. Anu Malik, and I am representing her here. So this is the overview and basic workup of a case of microbial keratitis. So microbial keratitis is proliferation of microbes associated inflammation and tissue destruction within the corneal layers. And the corneal ulcer is breach in the corneal epithelium with stromal infiltration. And abscess is when the epithelium is intact and there is corneal infiltration. So they are natural barriers to microbial keratitis, which are anatomical, like orbital rim, eyelids, cilia, intact epithelium of the cornea and conjunctiva, and mechanical barrier like tear film, blinking reflex, lacrimal drainage system, tear film, consisting of mucus layer, IgA complement, and lactoferrin, etc. So there are certain risk factors associated with corneal ulcer in which all these protective mechanisms are broken, which are like trauma, contact lenses, topical medications, ocular surface disease, bullous keratopathy, previous surgery, lid and adnexal pathologies, sac diseases, lid abnormalities like entropion, ectropion, misdirected cilia, etc. like ophthalmos, and systemic disease like diabetes, SJS, Sjogren's, AIDS, advanced malignancies, alcoholics, measles, etc. And occupational also like farmers, animal handlers, and gardeners. So epidemiology is in most of the studies, the majority consists of bacteria, which are mostly gram-positive, Staph aureus, Coagulase negative Staphylococcus, Streptococcus species, and gram-negative like Pseudomonas. Then 30% is Fusarium, which mostly is Fusarium aspergillus, Aspergillus flavus, niger, and candida. And viral is herpes simplex zoster and varicella zoster. And protozoa can be acanthamoeba, microsporidia, and others like nocardia and atypical mycobacteria. So there are stages of ulceration. One is the progressive stage in which there is social shaped, this necrosis and ulceration occurs with deeper penetration. Then there is regressive state in which there is healing, line of demarcation, margin and floor becomes smooth and transparent. And then there is stage 3, which is the healing stage where epithelialization starts. So symptoms we very well know: pain, redness, discharge, blepharospasm, defective vision, and signs also: discharge, corneal transparency, and epithelial defects, satellite lesions, etc. So we should document the patient's finding, which is very easy to do and help us in monitoring the patient. Those superficial vascularization is drawn in these red diverted lines, and corneal edema in blue, and infiltrate and ulcer is shown in green. Then grading is again mild ulcers less than 2 mm, depth less than 20%, no scleral involvement, moderate ulcer 2 to 5 mm, 20 to 50% depth, and severe ulcer more than 5 mm, more than 50% depth, and scleral involvement is present only in severe ulcers. So in bacterial keratitis, usually symptoms are severe. They are severe pain, rapid progression, mucopurulent discharge, mobile hypopyon, and normal corneal sensations. In fungal keratitis, usually it's an indolent slow course with elevated edges, dry looking surface, feathery margins, satellite lesions, fixed hypopyon, and it can be pigmented, and normal corneal sensations. So viral keratitis, corneal sensations are diminished, and it could have a fine lacy pattern, linear defect with Baird stroma. And acanthamoeba, the distinguishing feature is severe pain, and there will be history of fall of some dirty water or contact lenses, and there will be photophobia, and waxing and veining course will be there. And there are ring infiltrate, pseudodendrite, radial keratoneuritis, satellite lesion, ring shaped infiltrate, and severe limbitis. So acanthamoeba, apart from these, can mimic any of the 3 keratitis, whether it's fungal, viral, or bacterial. It can look like any of those. So in cases of investigations, we have to do corneal scraping. Ideally, we should do corneal scraping in each and every case. Besides the very small, less than 2 mm ulcers, we need not do the corneal scraping. Then conjunctival swab ideally should be taken, contact lens cases and solutions, and corneal biopsy, suture biopsy, and AC tap also may be needed in certain conditions. So the most important stains are gram stains and KOH. Other stains are specifically used in certain conditions, which are GIMSA, chalcofluorite, or ZN staining. So culture and sensitivity should be done, and most important are blood agar and chocolate agar, and non-nutrient agar for acanthamoeba, and then SDA media and brain-heart infusion. So investigations, if the patient is not responding with your staining and culture reports are also repeatedly negative, then corneal biopsy can be done and suture biopsy can be done. So corneal scraping is, if the ulcer is more than 2 mm in central, then always it has to be done. Then for corneal scraping, the already first speaker has explained the procedure. So for gram staining, we see these bunch-like, grape-like arrangement, and in gram-positive organism in chain, we see, so these are the different. So in KOH preparation, it is very simple, and we should all do KOH testing. We should just put the specimen, no need to even spread it. Just put 1 drop of 10% KOH and place the cover slip and examine under the microscope. KOH just loosens the stromal laminate, and you are able to see it under the microscope. If you don't have KOH, you can even stain with trypan blue staining, which we use in cataract surgery. So this is the picture how the yeast and the aspergillus looks like on KOH staining. And these are other stains, which respective picture like gram stain, GIMSA. And gram stain is best for bacteria and for visualized fungi and acanthamoeba. Even Microsporidia can also be seen in this. In Giemsa staining, bacteria, fungi, and chlamydia is the advantage in Giemsa staining, and Zn staining is usually for Mycobacterium and Nocardia. You can make out Mycobacterium with negative staining in gram staining. You will suspect it because there will be unstained areas, then you can do Zn staining. Acridine orange is done for bacteria, fungi, and acanthamoeba, and chalcofluor white is very useful for fungi and acanthamoeba, but needs special equipment. And then sensitivity and specificity, gram staining is very, its sensitivity is 32 to 98% and specificity is 99%. And KOH stain is sensitivity is 72 to 91 and specificity 99%. And if we are not able to diagnose with these, then we can take a corneal biopsy, especially if the ulcer is very deep. And if still the ulcer is very deep, corneal abscess, epithelium is intact, then we can just pass on a suture, a silk suture, and with a very small fragment, and then when we can cut that fragment into 2 pieces and send the 2 fragments for fungal and bacterial culture sensitivity. So direct plating on culture media is preferable, and it is easy to do also. For we should know the timing. Aerobic culture takes 7 days, and anaerobic to 7 to 14 days. And mycobacterial and fungal cultures take 4 to 6 weeks before reporting the no growth. So ASOCT can also be used for mainly monitoring the patient. So monitoring keratitis, especially deep stromal involvement and endothelial plaques, we can do ASOCT. And parameters measures are corneal thickness and infiltrate area, and infiltrate thickness and infiltrate width. And these can be monitored on progressive follow-ups of the patient. Confocal microscopy is useful only if the lesion is very deep. If you can scrape the patient, then confocal microscopy is of no use. But if you cannot scrape the patient is not responding to anything, then confocal microscopy can show you in vivo the organism, especially acanthamoeba cyst. So all these help us in establishing the correct diagnosis, identifying the causative organism, identifying the underlying risk factors, ocular as well as systemic, and assessing the response, and then managing for the recalcitrant cases. So risk factors should also be managed. If the patient is having blepharitis or dacrocystitis, trichiasis or legophthalmos, then you should manage the cause also. And if he is having ocular surface disorder, or if he is using contact lenses, then he should be taught about correct usage of contact lenses also. And then systemic conditions like diabetes and immunocompromised state should be managed. So scraping, the general management scheme is that after scraping, if fungal hyphae are seen, then you start with antifungal therapy with 5% netamycin. If you see on gram staining or culture sensitivity, gram ulcer which is less than, if you see organism on gram staining, then clinically, and the patient is clinically responding, then you can continue with the same treatment. If clinically it's not responding, then you have to change the treatment according to culture sensitivity. But if the patient is responding and your culture sensitivity shows some other organism, then you never change the treatment. You go for the clinical response only. So if the patient is not having any, then if the ulcer is less than 2 mm and superficial and it's not involving visual axis, then you can continue with your monotherapy with fluoroquinolone. If the ulcer is larger, more than 2 mm, and it involves the visual axis with deep stromal abscess, then you can give the combination therapy with fortified antibiotic drops with cefazolin and tobramycin. So if you have to document your findings so you can manage the progress of the patient. If you see good response, then continue the same treatment. If you see no response, then adjust the medicine according to the culture sensitivity. If again there is no response or progression, then discontinue the medicine for 24 hours and then repeat the scraping or corneal biopsy or culture. If it is a severe keratitis with scleral involvement, impending perforation, then you have to give systemic therapy also. Otherwise, systemic therapy or oral antibiotics are not recommended. If it is a perforated ulcer, less than 3 mm perforation is there, then you can go on with BCL and glue. Even Tinan's patch graft can also be done there. If it is more than 3 mm perforation, if it is central, then you have to do TPK. If it is peripheral, then you can do patch graft. So management, for the first 1 week, the ulcer is in sterilization phase. Then after the sterilization phase, you have to analyze the patient after 1 week, which comes to healing phase or 1 week. So the frequency of antibiotic administration is, first you have to give the loading dose every 5 minutes for first half an hour, then 1 hourly round the clock for 48 hours, and then 2 hourly until you see the healing of the epithelial defect. So usually the duration treatment, bacteria should respond within 3 to 5 days after healing. And the empiric management is, if it is bigger ulcer, then concentrated cefazolin and concentrated tobramycin. Then supportive therapy is pain management, cycloplegia, anti-inflammatory, lubricant, and anti-glaucoma. So after assessing the response, we can, if the patient, we can assess by reduction in sign and symptoms, and we can give these broad spectrum antibiotics. So monotherapy versus fortified antibiotic therapy is, if you are not able to form fortified, if the ulcer is very small, then you can give monotherapy. There are advantages: cheaper, readily available, stable, less toxic. But if the ulcer is larger, then you have to give fortified. So if already this has been covered. So if it is a non-healing microbiological keratitis, then organism, if it is traced, then correct antibiotic or specific antibiotic has to be started. And you have to see if it is an inadequate therapy, patient is not putting 1 hourly. You have to check the compliance, then increase the dosing to 1 hourly. If the patient is non-compliant, then you have to admit the patient, and you can also give subconjunctival injections. And then if the patient is immune compressed or drug toxicity issues are there, then systemic antibiotics can be given. If there are incorrect antibiotics, then you have to treat according to the culture sensitivity report and review after 1 week. If organism is not traced, you can repeat the scraping corneal, then even if no organism comes, and corneal biopsy, atypical microorganism or drug toxicity should be checked for. And then surgical intervention should be done. Thank you everyone for your patient listening.
So any questions on these topics?
KOH should be fresh.
No need, you can store it.
It's 10%
You can
or
prepare
20%?
and store it in a bottle.
It's 10% or 20%?
10%.
And you said probably if you don't have, you can use strip and glue also.
We can use tripaminols. So the KOH, what KOH is doing is it's just digesting the corneal lamellae. So trypan blue stains the fungal filaments. They, in LVPI, they are routinely using it in their peripheral divisions.
Because sometimes you don't, strip and glue is available
Yeah,
in a rural setup.
KOH you
But
cannot
KOH
store.
is
KOH you
not
cannot
use
store
strip and glue.
indefinitely. KOH you have to make after 1 month or so. So with trypan blue, storage problem is not there. So
And
KH,
it's readily available. You know,
it's readily available, and the process is same. You just have to put 1 drop of trypan blue and let it stay for some time and cover slip, and then you can see.
Sometimes
And
it's how long? For
it's
20 minutes?
30 seconds or so,
30
not
seconds.
much more, and it's even easier than KOH. The visualization is even easier than KOH.
Thank you. And what about intrastromal like antivenom like voriconazole and for?
Yes, sir. The thing is that if your patient is not responding, you can give intrastromal injections with TT syringe. You can give at multiple sites, 5 or 6, wherever the lesion is there. You have to inject in clear cornea around that lesion, and you have to see for the response, the same response as when we seal the wound of phaco, that stromal hydration is there, na? The same sort of appearance will be there. You have to inject it deep, but you have to keep in mind that the half-life of voriconazole is very less. It will go away in 20 minutes, around 20 minutes. So you have to give it repeatedly. 1 injection may not be suffice. You cannot say ki after 1 injection it's not effective. You have to repeat. You may have to repeat it 2 to 3 times also.
Any drops available commercial for acanthamoeba?
Acanthamoeba, no sir. No, voriconazole is also, you have to procure the PHMB. You can buy it from US actually. We have bought it from US.
Some
It is
people
a
are using probably dental, like like the mouthwash or
No, sir. Chlorhexidine is there. Chlorhexidine eye drops you can, but PHM, that is more epitheliotoxic. And in acanthamoeba, the treatment extends for even a year. It is very difficult because you can treat the organism on the surface, but there will be cyst which will be deep inside. They will again resurface. So you have to continue the treatment for a very long time. So you cannot give a very epitheliotoxic drug. So the choice of drug is PHMB, which is lesser epitheliotoxic.
I remember there's something called golden eye drop from UK, somebody I saw with somebody.
PHMB is provided by Orolab people, so
Yes, sir. And Shroff Eye Center also provides it. But you have to send the patient with the 2 lubricant drops. Shroff Eye Center in Delhi, because I am from Meerut, nearby Delhi, so I can tell you about that. So they provide PHMB, prepared PHMB. You have to send the patient or their relative. Patient need not to go. Patient has to go with 2 lubricant eye drop and your referral that you need PHMB, and you are suspecting a acanthamoeba keratitis. So they will provide the PHMB eye drops. They will be valid for 1 week only. Then again you will have to. And first of all, the main problem is that you have to establish the diagnosis of acanthamoeba first.
Ma'am, till how many days we can give eye ointment acyclovir? We say we have to give for 14 days.
for iridocyclitis.
For normal keratitis.
So for 10 weeks we had to give.
For 10 weeks.
Yeah, until you give the topical steroids. So you have to give acyclovir also, oral acyclovir.
Ma'am, eye ointment. Acyclovir eye ointment.
You can continue until the topical steroids, because when you are putting topical steroids, the epithelial keratitis can occur again. So that's why we give.
Thank you.
What about a patient with significant cataract and then, old herpetic, healed ulcers? How do you go?
So at least there should not be any recurrence, at least for 1 year.
No active.
No active. So you have to keep the patient on prophylaxis at least for 1 year. It's 400 mg.
See, in a rural area, you have a very significant cataract, and then this person had a old, this herpetic keratitis, and he needs surgeries for rehabilitation.
So we have to explain the patient that there can be resurgence of viral keratitis, and in the post-operative period you can keep the patient on prophylaxis again.
And that prophylaxis for 1 year.
Yeah. So because the recurrences are more common within the first 1 year, so they have advised to give prophylaxis in the first 1 year. So after 1 year, the recurrence chances comes down. So the head study has...
Patient comes to me with an whitish opacity, there's old KPs, no AC reaction, significant cataract. I can go ahead with the cataract surgery under antiviral prophylaxis.
Yes, you can go.
And that prophylaxis will continue for about 1 year.
Yes. It is better to continue the prophylaxis.
And
Then the chance of recurrence will come down.
So acyclovir 400 milligram in BD doses
Yes.
for 1 year.
Yes.
And after every 3 months I have to check for liver function test and
It is better to do if the renal profile and liver profile. So every 3 months. You have to follow the patient every 3 months. Because we have to see the compliance also. Sometimes the patient will stop on their own acyclovir. So it is better to see the patient every 3 months, even though he doesn't have any recurrence. So any other questions? I think we have come to the end of this session, if there are no questions. Thank you very much for all the audience for active listening.